Dr. Gulam sir is not there?
Yeah, sir, sir is not there. We have taken actually permission. I'm presenting on the behalf of Dr. Gulam Ali Kamdar, sir.
You have taken permission of the scientific committee?
Yes, sir.
Okay, thank you. So, what is your name,
Dr.
please?
Rajshri Hirawat.
Dr. Rashi will be speaking on restoring vision with scleral fixation of toric IOL in complex trauma cases. Dr. Rashi, please.
Exploring an innovative solution for ocular trauma, suture fixation of toric IOL for visual rehabilitation. Managing ocular trauma is complex with challenges in assessment, inflammation, prosthesis choice. Today we present two cases and a novel visual rehabilitation solution. A 51-year-old male underwent corneal tear repair, subsequent retinal detachment surgery. Post-silicone oil removal, vision improved to 612 but 6.52 diopter astigmatism, traumatic mydriasis and aphakia hindered further visual rehabilitation. Though options for rigid gas permeable lenses and SFR were there, we wanted a solution that could provide spectacle corrected vision while addressing other challenges simultaneously. Enter our novel approach. Instead of conventional capsular bag implantation, we choose suture fixation of toric IOL with residual astigmatism of 1.99 diopter. Pre-operative slit lamp and intraoperative toric axis marking were done. Limited conjunctival opening were made at 3 and 9 o'clock with careful cauterization. Two 3 into 3 mm scleral flaps were created at the toric axis. An SNQ scleral tunnel was repaired for IOL insertion. A tenopropylene suture was passed 1.5 mm from the limbus, docked into a 26 gauge needle and repeated for the second needle. The sutures were extracted, cut and tied at the optic-haptic junction in a 3-to-1 fashion. The IOL was positioned by pulling the sutures under the scleral flap, followed by a careful titration and toric axis alignment. Finally, a single pass 4-throw pupilloplasty was performed to correct traumatic mydriasis and optimize pupil size. 2-week post-op, vision improved to 6/18. 30-month follow-up, the vision was 6/9 with 1.52 residual astigmatism. UBM confirmed centered toric IOL with no tilt. Our second case was a 21-year-old male with post-traumatic corneal fibrovascular scar, cataract and eccentric pupil. Previous record showed BCB of 6/9 with -4 diopter cylinder. Online toric power calculator showed residual astigmatism of 0.067 diopter. Pre-operative slit lamp and intraoperative toric axis marking were completed. Phacoemulsification with in-the-bag toric IOL implantation was planned initially, but a calcified cataract tightly adhered in one quadrant required a pars plana approach for extraction. Two 3 into 3 mm partial thickness scleral flaps were created on the toric axis. A clear corneal tunnel was prepared for IOL insertion, and a 4-point horizontal fixation was done using Gore-Tex sutures past 3 mm from the limbus. The sutures were looped into the junction of optic and haptic of the toric IOL, and after careful titration, final tying and toric axis alignment were confirmed. The 7-month follow-up showed well-centered toric IOL, uncorrected visual acuity 6/12 and best corrected visual acuity 6/9 with -0.5 diopter sphere. Conventionally, toric IOL are implanted in the capsular bag. Our innovative approach of suture fixation is proving to be a game changer. These cases, unique to the Indian scenario, showcase the potential of this technique in addressing significant astigmatism with no capsular support. Management after ocular trauma indeed be challenging due to the complex nature of injuries and the delicate anatomy of the eye. Each of these challenges require a tailored approach integrating surgical expertise, careful postoperative management, and a long-term rehabilitation plan. Collaboration among ophthalmologists and optometrists is often necessary to optimize the outcome.
Thank you, Dr. Rashi. For paucity of time, we'll just take one question because the main presenter is not here. Sir, any question you want to ask?
You reported very good results, but I was a little skeptical because this astigmatism is a little unstable in such cases and it takes a long time to recover.
Yes, sir.
But I would go with whatever you.
Yeah, sir. Actually, we have performed surgery. As you said, we have waited for 1 year after silicone oil removal. When the refraction was stable, then only we planned it. because
But I think we need to understand in these post-trauma cases, it is basically the curvature of the cornea which has changed because of the corneal tear. So it's more the corneal astigmatism that we are dealing with, and often these patients would require an RGP contact lens to overcome that. So I was wondering that how much that can be overcome by putting in a toric IOL.
so ma'am, initially we planned for the RGP only. With RGP, patient was improving 612. So that's why we thought patient has a visual acuity. Why not we should take a chance while doing this kind of surgery? And this patient, first patient has finished 3 years follow-up till now. So residual refraction is stable, and everything is stable. Patient is maintaining good vision. There is no tilt. And the second patient also have completed 1 year follow-up.